morning, everybody. So the next section will be about the interesting topic of fracture-related infection. So first, I want to introduce Dr. Puripan Jilangun about the topic of to retain or remove the infected implant, current evidence.
Thank you. Good morning, Chairman, Co-Chairman, and audience. I'm honored to be here to share the current evidence about the infection after fracture fixation to retain or remove the infected implant. Okay, I think everyone in here among us used to deal with this problem. It is a big problem, right? Some study report the incidence of IAFF for closed fracture only 1 or 2%, but in open fracture it reaching up to 30%. However, the real incidence of IAFF is probably underestimated due to a lack of precise definition. Okay, when you're looking to the past, its definition was still unclear, but this is a good news. After 2018, with the support of the AO Foundation, we have the definition of IAFF. When you find the IAFF in the current literature, many studies have concentrated on periprosthetic joint infection because the treatment of IAFF are adaptation of algorithm found in prosthetic infection management. But those of two identity must be distinguished. This is a key message. While the ultimate goal in treatment of the infected joint is the eradication of infection and sterile implant. But the goal of the treatment of an IAFF is the healing, I emphasize, is the healing of the fracture and the avoiding of chronic osteomyelitis. These are the criteria for diagnosis IAFF. There are many details, you can see it. But for today, I would sum up of these criteria in a nutshell for everyone in here. Okay, here we go. You can see the confirmatory criteria. The confirmatory criteria, it is a chronic sinus drainage, positive intraoperative culture at least 2 times, and positive tissue culture. This is the confirmatory criteria for diagnosis IAFF. The next one is the suggestive criteria. For the clinical signs, it is a signs of inflammation and the new onset of wound drainage. The radiographic signing is about the implant loosening, non-union. And the last one about the microbiology and laboratory investigation is about the positive tissue culture. But the microbiology, I would emphasize everyone that positive tissue culture, not swab culture from the superficial swab culture. Yes, this is very important. For the classification, it's very simple. According to time, following onset of the patient symptoms, they are classified into 3 groups: early, delay, and late onset infection. For the early IAFF, it's present with classic and systemic sign of infection. Within this period, the causative bacteria may already form biofilm, but it's still immature in the early phase. For the delay phase, infections are typically due to less virulent bacteria such as Staph epidermidis or Cutibacterium acne. In this situation, biofilm is mature and more resistant to antibiotic therapy. The patient can present with the symptom either early or late infection. And the last one, the late onset infection are primarily caused by low virulent microorganisms such as Staph epididymis. The compromised fracture healing is frequent observation in the infection as is osteomyelitis with sequestrum or involucrum. In the clinical side, this is a very common presentation feature with pain, redness, swelling with sinus tract drainage. And for the fever, it is a very unspecific. The specificity is quite low. For the laboratory investigation, leukocyte count, ESR, and CRP are commonly used for everyone for investigation. But in addition, new markers such as interleukin-6 combined with CRP seem to be interesting in detect low-grade infection, but they are not to be used in primary intention in all cases. For the X-ray, it is a low sensibility and specificity in diagnosis IFF, but it remains the first step for everyone for the bone assessment for exclude other causes such as malreduction, malposition of the implant or loss of reduction. The CT scan may show the sequestrum or involucrum. The bone scan is a good solution for detecting early detection and good sensibility, but the problem of the bone scan is low specificity and residual contact uptake until 1 to 2 years after initial trauma. And for the bacteriology, infected microorganisms should be identified, their antibiotic sensitivity defined, and appropriate specific antibiotic administered. And again, no superficial tissue sinus, no superficial tissue or sinus tag swab. For the treatment, this is an important point. Our goal are treating the infection, healing the fracture, preserving soft tissue, and obtain the optimal restitution of the patient function. The immediate treatment of the infection is not always the priority. The bone healing can be the primary objective as the internal fixation device can be removed once consolidation of the bone is obtained. So suppressive treatment has a place in this treatment. For the first question you should ask yourself is, did the fracture consolidate? If the fracture has healed, the treatment would be a drip by brain and complete remove of the internal fixation device, followed by 2 weeks of IV antibiotic and 4 weeks for oral form antibiotics. On the other way, if the fracture has not completely healed, timing of initial infection onset is important. The biofilm appear after a few hours, but this does not seem always prevent the fracture callus formation. In case of early infection, the following questions are: is the implant stable? Is the reduction acceptable? And the last one is about the skin closure. Is possible or not? If the criterion of acceptable reduction is fulfilled and the implant is stable and safe cutaneous situation, a solution can be debridement with retention of implant followed by 12 weeks of antibiotics. If the implant is unstable with a poor reduction, the soft tissue closure is not possible. The surgical option should be implant removal, temporary fixation, internal or external, with 6 weeks of antibiotic treatment, followed by new internal fixation at 6 weeks together with antibiotic 6 weeks thereafter. Yes, okay. And for the lead infection, the treatment of the lead infection must be finding the sequence stump and the dead bone. Bone breathing must be evaluated in order to know the vitality of the bone. Dead bone resection may give a significant loss of stability and necessitate more complicated reconstruction methods, such as the Mascaro technique, the bone transport, something like this. And for the infected intermedullary nail, this is the special situation. Due to the nature of the fixation, the IM nail spreading infection occur frequently. Most of them need to remove the nail. In general, the early infection only require the antibiotic administration with or without debridement. And for delay infection, it can be successfully treated with nail removal followed by placement of antibiotic nail and administration of antibiotic. And the last one, for the late stage infection, infected non-union can successfully be treated with nail removal with Elisarov frame application, especially when the large bone defect exists. Okay, for the antibiotic therapy, when implants are retained, a curative treatment is generally only effective of biofilm active antibiotic administered. Up until now, only rifampicin has shown to be effective against staphylococci and quinolone against gram-negative bacteria. The proper antibiotic must be adjusted follow the tissue culture report, and it should be discussed with infectious disease specialists. The appropriate use of antibiotic should be administered by IV 2 to 4 weeks. If the evidence of bone healing is still not occur, the device should be retained up to 3 months. And for the take-home message, I would conclude everyone. The first one, our goal is bone healing without osteomyelitis. Early diagnosis and multidisciplinary planning is necessary, and it's the key point for successfully treating for this kind of infection. The appropriate taking specimen for culture, again, positive tissue, only positive tissue culture, not superficial swab culture. Early and proper debridement every time when you suspect the infection. This is very important. A stable page with no aggressive infection may be retained, but nail usually require removal. The soft tissue coverage can help to obtain the bony healing. And the last one, culture-directed antibiotic until union. Thank you very much for your attention.
Thank you, Dr. Pulipan, for summarizing us about the infection after fracture fixation. So next, I would like to introduce Dr. Salantan Tavisut to talk about update in local antibiotic delivery.
Okay, good morning, everyone. So the topic would be update in local antibiotics. I'm Saran from Chulalongkorn University. So after this lecture, you're supposed to understand the role of local antibiotics with or for the infection prophylaxis, treatment, and I'll show you some advance in local antibiotic delivery. All right. So local antibiotics also can be used as the infection prophylaxis. All right. So why we need a prophylaxis? Because in an open fractures, even with the standard treatment technique, like if you debride it the best you can, you give the patient the systematic antibiotics, the risk of infection still be around 4 to 60% in some literatures. And that's why we want to further decrease the chance of infection. And local antibiotics can help you with this. It also help you reduce the chance to have a biofilm on the instrument. Okay. And in trauma situation, the soft tissue in that area is bad, right? It's get hit hard, the bone is fractured, the soft tissue is stripped, bruising, the vascular in that area is also bad. So that is why the delivery of the IV antibiotics is difficult to reach into that area. But local antibiotics can solve this pain point because you add antibiotics directly into the injured area. You have high concentration of antibiotics with lower risk of systematic complication because it's local, right? So you have a less chance to get like nephrotoxics or ototoxics. If you want to like increase an IV level up high and hope it's gonna increase the level of antibiotic in the injured area, you might have consequence with antibiotic toxicity. But there are also some concern about local antibiotics. As I tell you, it increases the level of concentration at the local site, right? In some literature, it said that the level of the antibiotics, even up to 1,000 times of MIC. All right, MIC is like a minimal concentration that you need to kill the bacteria. In some literature, they say that once you dump antibiotics inside the local, it's increased up to several hundred or thousand times. And that can cause a local tissue toxicity. And in some rare report, it also has systemic toxicity. It's shocking, right? You imagine that, okay, I use the local antibiotics, but the next day your patient has renal toxicity, renal failure. It's happened, but it's rare. And most of the patient that has this problem is elderly. So you have to be careful using a high dose of local antibiotics in elderly patient because it increases the chance of systemic toxicity. But good news is there are no report about delay union or non-union with the local antibiotics yet. So you can use it without compromisation in bone healing. So to prophylaxis, the easiest way, and I think some of you might already use this. This is off-label use, but seems to have a potential to prevent infection. It's a naked way. You just pour or sprinkle the powder of vancomycin in the like a high risk of infection area, and you just close the soft tissue. All right. The first field that use this is spine surgeon. Okay. So they just sprinkle the powder in there. Or you can just dissolve the powder in the sterile water and soak your injured area before you close. That is another way. So there are not many high or good design study about this. This is the best in the system at this moment. This is RCT. They recruit the patient with closed and open tibial plateau and pilon fracture from 34 US trauma centers. And this is RCT, the only RCT available at this moment, right? And the outcome is they try to see that are there any difference in deep surgical site infection at 6 months or not? So they compare the first group is a control group. The second group is a vancomycin group. So they give 1 gram of powder sprinkled into this surgical site before they close it. Interestingly, the overall infection rate is not significant, but very close. Is favor the Vanco group. The gram-negative infection was equal between both groups, but the positive is the gram-positive infection is significantly reduced in Vanco group, right? And they suggest that this is a low chance of complication, it's cheap, it's easy to do. If you have a case that you're worried about gram-positive infection, this can be helped with a very low complication. There are another way to apply local antibiotics is apply with carrier. That means you might attach your antibiotic with something. It can be a soft, it can be hard, it can be whatever you want. Like Ajahn Chitavi demonstrated yesterday. You can even use a hydroxyapatite as a carrier and you can get like a bone healing boost to your patient in that area. That would be very helpful as well. So one thing that comes with carrier is you have a chance or ability to control and release whatever you want. You can custom. You want it to release for a long time, you can do it. You want it to release for a very short time, but with a high concentration, you can do it in the lab. You can like a prefabricate before you use, right? And you're gonna know the pharmacokinetics before you use it, and that's very important. So the carrier can be anything. It can be bone cement, it can be biodegradable ceramics, it can be hydrogel, it can be something else. And yes, it comes with more prices. You have to pay more to get carrier. And most of the time it's used in treatment. Okay, so now we enter the treatment zone, right? So to treat the FRI, so you know that it's not just local antibiotics. You need all of these in a good qualities, then you can win this war. Local antibiotics is only one factor, but it's a very important factor because every time you have a thoroughly debridement, you always create a dead cavities, which can be a reservoir for a bacteria that's still left after your debridement. So this cavity need to be treated, need to be managed effectively, or you get recurrent infection. And the local antibiotics do the job well in this area because you can fill up that dead space with something that can kill the rest of the bacteria. And it's also eliminate the dead space for you. That's what you want in this situation. Okay, the most basic carrier and space filling that can kill bacteria for you is bone cement or PMMA. We are all very familiar with this. Okay, it's good because it's available anywhere. Okay, you can make it as a beads, a block. It can be molded into whatever shape you want. You can dump whatever antibiotics you want, but be careful. Only some kind of antibiotics work with bone cement. It has to be a heat stable antibiotics. Because when the bone cement cured, it generates a lot of heat, right? If you just use the antibiotics that it cannot tolerate the heat, you just add nothing into the bone cement. Okay, and you can use as much as you need, as long as you can pay for the bone cement, and you know that you're not gonna heat the bone to death, right? And it can provide some mechanical stability as well, right? Because of heat stability limit, there are most common antibiotic find with bone cement. This is all these, like a Vanco, Tobra, Genta. These three are a classic and very work with the bone cement. And it's not resorbable. You have to remove it. This is a downside. Cement beads, this is classic form. You can use it, no structural integrity, and it effectively fill up the dead space. And the high level of antibiotic elution can be expected because it has a lot of surface area. The more surface area you have, the higher antibiotics you have. Not only a shape, this is one of my work. If you can do whatever that make the cement has more surface area, you can have higher antibiotic release. Like this one, I just mix the bone cement with chitosan. This is a very simple thing. Once you implant, the chitosan just resolve, leave a small hole. A tons of small hole increase several 100% of surface area to release antibiotics. So you get more antibiotics. Cement can be coated on the IM nail to release the antibiotics inside IM infection. Okay, let's have a look at this. This is a picture from the literature. This is infection, non-union. So the treatment is they remove the nail, they cut the infected part, and then they insert the cemented nail with cement beads. Because of what? Because at this stage, they need the highest possible release of antibiotics. And this can do the job. The cement nail kill the germ in the IM area. The beads release a lot of antibiotics in this area. And then they revise this. The cement nail still there, but they change into a block just to prepare this area for mascale. And at the end, they switch to a definite nail with bone graft and it's healed pretty nicely. Carrier can be ceramic. This can be resorbed. The result is close to bone cement. Because it can be absorbed, you don't need a secondary surgery to remove it. But during the process of create this thing, you have to pass like a method with a high thermal. So the antibiotics still have to be able to tolerate and limit option for antibiotics. The hydrogel, this is no limitation on antibiotic type because you just mix your antibiotics inside the like a controlled release gel, but there are no structural support. So there's pros and cons. You have to pick what you want in your case. So there are some advances in local antibiotics delivery. There are tons of research going on at this moment all around the world because we know that we hate infection, right? Everybody hates infection, so we all try to find a solution to win this. But this is the concept. Basically, the research just go around this picture chart. So they are trying to make a new scaffold, which can be metal, ceramics, like a polymer, and try to mix with something that can kill germ. They can mix everything together, even with the bone graft. All of these are like a process. The scaffold can be anything. It can be like a classic type. You can implant this. You can 3D this. Now the 3D technology is here, right? So that you just print the defect, load with something that can kill germ, and implant into your defect. It can be even injectable. These are very new field and very profitable to use in the future as well. Even in the metal, would be nice if you can have an implant that can kill bacteria by itself. With other kind of carrier, one concern is when you implant it for a long time enough, the release rate is getting low. And then you're gonna start to create bacteria resistance to a low level of antibiotics. But if it's in the metal, it can release like an ion that kill bacteria for a very long time. Even if it gets scratched or whatever, it still can protect itself from biofilm. And this is also one of my work. Just try to find something to coat on the metal, and hopefully it can reduce the rate of infection and biofilm. This is another one. You can even modify the surface of the metal. Like this, you use anodization to make a nanotube on the surface of metal, and you can load the antibiotics inside, and you can control release how long you want, what concentration you need. This is one of the work of my team as well. All right, so I think time is up. So the take-home message, the naked antibiotics seem to have a role to prophylaxis against gram-positive bacteria. The carrier help you provide a sustained release with a various strength of structural support, depend on what kind of carrier you use. And local antibiotics provide high local antibiotic concentration with less systemic toxicity. But be careful in elderly patients. Don't use too much concentration in this group of patients. Thank you.
Thank you อาจารย์สรันครับ Okay may I invite the panelists Dr. Saran please stay on the stage and anyone can bring the chair here and Dr. Sukhanit Chomchun from Thammasat Dr. Wich from Songkhla okay here we go we have two case discussions the first one is Dr. Pasit Seng Panit and the second one is me. And for the question and answer, is there any question here to ask Dr. Saran or Dr. Puripan right now during the preparation? May I ask Dr. Saran? May I ask Dr. Saran? I have seafood allergy. So if I got infection and I have to use your chitosan, is there possibility to have allergy with the chitosan?
Then you should stay on the safe side. Chitosan is made of some shellfish animals. So there are other like a synthetic beads that can be mixed and also dissolved in the water. You can use those kind of stuff as well. And like I tell you, the principle is just try to get more porous in the cement, right? So when you do bone cement for antibiotic release, you use your hand to mix it, okay? So when you use it for primary, you need strength, correct? That's why you use centrifugation, you use vacuum mixing. That can reduce porosity and increase strength for your cement for a long-term use. But when you use cement for antibiotic release purpose, let's say you need a bad cement. You need cement with porous. Then hand mix is the best solution. All right. You can even add two kinds of antibiotics. That's gonna add a lot of porous inside the cement. There are so many ways to increase the rate of elution.
Thank you. Okay, Dr. Pasit.
Thank you. Good morning, everyone. My name is Pasit Seng Panit from Puttachinarat Hospital, Phitsanulok. Today, I'm proud to present the case discussion about the fracture-related infection. Let's start with the case. A 21-year-old male, he come to hospital with a motorcycle accident, and then he had the open wound and deformity at the left leg. This is the wound, and the film show segmental fracture of distal tibia and comminuted fracture of fibula. At the first hospital, they decide to debridement and put the external fixation, and then they convert to internal fixation with anterolateral distal tibial LCP and fixation the fibula with pinning. This is the 1 month after follow-up, the 3 month, and the 6 month. As we can see, after 6 months, the fracture still non-union. And unfortunately, he had an open wound with the chronic pus discharge from the wound. So they decide to remove the plate. And then they still wait until 1 year after injury. The fracture still non-union and the wound still have a discharge from the wound. And then they refer to my hospital. I work up, ESR is 56 and CRP is 18. For diagnosis, this case's diagnosis is infected non-union of distal tibia. I want to ask the panelists, what is your plan for treatment for this case? 1 year after injury.
Okay. So for the diagnosis is fulfill of the criteria. have the confirmatory criteria that you see the pus, and also the rising criteria, rising of ESR-CRP, and also have the evidence of non-union of the X-ray is fulfill of infection. So what we have to do, we have to confirm which pathogen does this patient have. What we have to do is just take the culture and irrigate debridement and span it with X weeks and wait and see.
I would like to ask first, do we have a pathogen right now, the culture result? Because it's already 1 year, right?
Yes,
We
one
should have
year.
something.
For this case, he come to my hospital after 1 year after injury. I take the I take the culture. The culture is negative because I think they got the long time of antibiotic.
And right now it's still on antibiotic, or we already
Oh, still on
Stop.
before
Ah.
before refer to my hospital.
first. I will stop antibiotic first because it will be higher yield to get the organism at least 2 weeks. I think this is the most important thing to deal with the infection. We need to know
Yes.
what we fight. Okay, so I will stop antibiotic and get a culture. And what you did in this case, you stop antibiotic or
Oh, at that time I stopped antibiotic first, and
What?
then we watch for something before do anything.
okay, and after it get a culture, it's still negative.
Still negative.
Okay, and this is classic, right? Because the chance that you can get a positive in the culture is only 50%. There are even journal dedicated for only how to increase the chance of success when you do culture. All right, I would like to share with you a little bit about this. Can you go back a couple of slides, please, before you remove the plate? Okay. Yeah, here. When you have a definite infection, like you have a pus and you plan to go inside to remove the plates. So what you should do is try your best to increase the chance of positive culture. All right. There are several things you can do. Like the first thing, you're supposed to stop antibiotics, every antibiotics, at least 2 weeks before getting into the field. All right. The second, you should get the sample from several sites. One of the best sites supposed to be at the implant bone interface. Those are a high chance that you get the samples. And if you are really hardcore and extreme, every sample that you pick, you should change new instrument to retrieve it. So you can prevent yourself from contaminate from the first piece to the last piece. All right. So every pick supposed to have a new instrument, new scissors, new clamp, whatever to keep it. Even the number of the pieces that you take count. If you take only 2-3 pieces, the chance is significantly lower than you take 5 pieces or more. So when you take the sample, take at least 5 pieces. All right, and then you can give antibiotics to the patient right after you collect samples. All right, and even when you culture, you have to talk to your lab. Like some bacteria are slow grow, you might have to let them keep it in the incubator for more than 7 days, or would be the best if it's more than 14 days. And try to think about various type of microorganism. You might have to try to culture it in like a aerobic, anaerobic. Just try everywhere, and you're gonna be able to increase the chance of finding that pathogen. Because like Ajahn Sukhanit said, it's the best if you know who are you fighting with, so you can pick the right weapon to fight. All right. If not, what you can do is you have to pick a broad spectrum antibiotics. It might work, but it's better if you know what is your enemy.
And another thing is that you have to do like further investigation to see like skip infection.
Yes.
You can do MRI,
Mhm.
or nowadays there's a role of the white cell scan or PET scan, but it's not feasible in our country. PET scan is quite expensive, and patient have to pay by himself. It's around 50,000. And for the DEXA, or a SPECT scan, the queue is quite long in our country. So I think MRI could give in terms of anatomical relationship to see how much do we have to do the debridement.
And I will consult ID.
Yes.
Which is first, because sometimes they would like to get something like a culture and they specify what they need. Because if we consult after the operation, maybe we cannot get it at that time and we have to go back again. Okay, this is important thing. And also the deep soft tissue or bone sample is the must, not like a sinus tract or skin that is not reliable. Okay, and also the plate when we remove it, maybe that one we should send it. And we have some special technique that we call sonification of the plate. We put in the water and use a frequency, and then we get the organism out of the implant that maybe get higher yield of the organism. Positive. Okay.
Thank you. Okay. Thank you for your comment. For this case, I think about the strategy, my strategy to treatment the infected non-union.
After you remove the plate, didn't you add any kind of like a fixation to the leg at all, like a X-fix or something like that?
At the first hospital, they just only remove and wait until 6 months before refer.
We're not here, right? Ajahn Puripan already mentioned no stability, no healing, because it will move and it break the vascularize to the bone, and we will fail, we will lose.
Okay, thank you.
And
I think like you. My strategy, the first thing, I think about the radical debridement for the remove all the infection and infected tissue to eradication the infection. The second, I think about the establish the stable fixation for improve the stability. And the last thing, I think about the soft tissue reconstruction for provide the biologic environment to promote the bone healing and to combat the infection. So, for this case, at my hospital, I restart everything again. I start with the radical debridement to remove the poor quality skin and remove the infected tissue and debride the fracture site. And then I left the wound open. And then I put the external fixation. This is the wound after debridement and put an external fixation. The film is on the external fix. After that, I wait until the normal ESI and CRP, and the wound was good. After 14 days, I think about the established stable fixation. I concern about the poor bone quality from the lateral side after the first internal fixation. So I decide to put the plate on the medial side with the distal medial tibial LCP, and then I augment with the distal radius LCP on the anterior side. And the most important thing is about the soft tissue reconstruction. I use the local fab with the sural fab to cover the wound defect and to provide the environment for healing. This is the wound after fix and flap. And this is the film. I think alignment is okay, but still have a gap on the fracture after we debridement. After the flap is survived and the infection is clear, I put the bone graft in the fracture site. And then I follow up at 1 month, 3 months, 6 months, and 1 year. And the last time is for 18 months. I think the wound is okay. The infection is clear and he can walk independently. So for the take-home message, for the strategy of the treatment of the infected non-union, the first thing is about the radical debridement to remove all of infected tissue. After that, we think about the S-bit stable fixation for improve the stability to cure the infection. And the last thing is about the soft tissue reconstruction. The fab coverage for the infected non-union provide the biologic environment to promote the bone healing and to combat the infection, and provide the space for the implant and provide the space for the bone graft, I think. Thank you.
Could I ask the idea of panelists? If you see this segmental fragment and open like this, and this fragment float away outside, do you think that you're going to keep this fragment or try to preserve it and put it back and let it heal? It could be a sort
You
of
mean
infection.
the first
the
at
middle
the first
fragment.
visit, right?
Yeah.
I would keep it absolutely, because if it's a big segmental and it's like a provide like a critical structural support for the whole bone, I'll give it a chance, right? So doesn't mean that I'm gonna keep it forever, but as the first try, I think I will like try to clean up the best I can and like give it a chance for at least couple of days. All right. So I would like to add on this a little bit. So you put an X fix on and wait for how long before you go back for a definite treatment?
14 days.
14 days.
Yes.
That's very brave. Okay. And what do you use to determine that this is the right time to go inside and do definite treatment? Do you have anything to monitor?
For my opinion, if I left the wound open, I can look for the tissue on that area, and the laboratory help me for the result as the ESR and CRP. So I think the wound is good. No pus discharge. The wound is not infected. I decide to do it.
Okay, so just to share with you, my approach would be different. So I agree with redebridement the best I can and put X fix on. All right, but at the first 14 days, all the biomarkers are pretty unreliable, ESR, CRP, white blood cell, and I would prefer to have at least a period of antibiotic freeze before I go inside, just to make sure that even no antibiotics, there are no reinfection. So I would wait longer and maybe at least way more than this and follow the ESR, CRP, and clinical symptoms.
Yes.
And once everything subsides, then I plan to go inside. And one thing that we have to be prepared is the bone loss as well. Okay, so debride, soft tissue coverage, yes, and prepare to deal with the bone loss, because every time you do this, you have to debride some bone out. All right, and maybe it would be a great thing to have if you can have some investigation before do your like a radical debridement, like Ajahn Wich said, maybe PET CT scan if you can, PET MRI, thoracic or even MRI, so you can get an idea like that segmental is still alive or not.
Okay.
Okay, thank you for the interesting case and
Thank you.
also the comment. So we are a little bit late behind the time.
But
So
anyway, congratulations to the case. It's
Yeah.
ended up very perfectly.
I think the key is that you resect all the poor soft tissue
Yes.
and cover with the good soft tissue, so provide a good vascularization. So this is the key
Yes.
thing. Yeah.
For me.
Without this, I think we will wait until bone dead. That segment. Okay. Thank you so much.
Thank you. Thank you, everyone.
okay, the next case will be presented by our co-moderator, Dr. Krisakon Srisom.
สวัสดีครับGood morning ครับอาจารย์เคสยาวหน่อยนะครับแต่พยายามจะให้มันแค่เอาเฉพาะเนื้อหาเรานะครับ Okay, my name is Kiskon Sisom. So this is my case with Dr. Wachara. Okay, this is my case. 19 years old, Myanmar guys. He works in the jungle. The motorcycle accident happened 7 weeks before he met me. This is the first picture that he met me at the OPD. Okay, this is the X-ray. 7 weeks. He have been done 4 operations at China border between China and Myanmar. And 7 weeks after that, he came to me. This is the picture. This is not bone, not his bone. I think this is the bone cement. If you can see, it will be some hole here, and when you look inside, it's have the cement with some pus oozing a lot. And this is the first X-ray from the Myanmar. The first operation is have done in the China. Multiple KY on the supracondyle and debridement. And the second operation is in the Myanmar hospital, rural area in Myanmar between China and Myanmar. So this is the questions. How can you manage this? The big piece of the humerus, as the doctor will ask, keep it or bring it out with multiple pieces like this? What do you prefer?
I see the bone is still okay because that is very far away. I think it's still okay. I will try to keep it first, and I will do the aggressive debridement. If you see the sinus tract on the lateral side, I will eradicate resection, like the tumor idea, right? In the wet chaff, and after that, I will put the beads in the last form, multi beads, and because it got the E. coli and I can't remember.
Yeah.
It should be gram positive, gram negative, right?
It's E. coli and Pseudomonas aeruginosa that's cultured in Thailand, not in Myanmar.
Okay, I will put the beads. In PSU, we got many kind of beads, such as like colistin bead or gentamicin. You can choose the gentamicin first, and then take the culture again and check the scent and specific. And after that, do the multiple debridement and to see how it's going on that the floating fragment.
I think it's no reason to take it out, right?
Mm-hmm.
Initial. Not
Initially.
right now. Not in your hospital. So we keep it, and I think the construct is not good enough, right?
It's not so good.
Yeah.
So the second doctor remove the pin now and replace it with the egg fix, the big one.
Do they fix across to a forearm in this case? No.
Yes, as the picture like this. And he also have the brachial plexus injuries. He cannot. His radial nerve is gone. He cannot do the wrist extensor.
At this stage, is it infected yet?
Yes.
So with this picture, it's already infected.
Yes, with the patient history, he said that he don't know what's going on at the hospital. Okay. There's a lot of pus and foul smell from his hand, so that's why he want to come to see the doctor in Thailand.
Okay, so if I see the patient with that stage, I will try my best to keep that middle piece as well. So what I'll do is I will adjust X-Fix to make it have a better alignment, less gap. But I also gonna try to keep the joint, because once I see the patient come to me like this, it's gonna be a long battle. It's gonna be a long time. If the joint is like badly displaced, even if we win the battle of infection, we're gonna get bad function anyway. So what I'll do, I might at the joint, I might remove the big pin out and might try to reduce and maybe shoot maybe 1 pin or 2 pins and just leave it outside. Just in case if it's getting worse, I'm just pull the pins out. But if it's not bad, at least this pin gonna keep the joint for me. And if I win the battle of infection, I can have a reasonably okay joint, right? And I might just do the pin in the forearm just to bypass this area.
And what the cement type that you want, you prefer to discuss?
At
The
this
cement beads at this stage,
right?
yeah.
At this stage, if there are not many bone gap, we have to use the cement beads, right? So cement block maybe is not proper at this stage, because I think if I can reduce everything back in place and it look like a humerus, maybe there gonna be only a small gap for me. And at this stage, I need a high concentration of antibiotics, so the beads would do the job.
And how long that you will exchange the beads or the cement spacer?
I think it also depends on the symptoms. All right. So this is multifactorial. We are dealing with like a, let's say, late infection. So it's full blown. So it all depends on the quality of debridement, depends on the pathogen. If it's so aggressive, you might have to change it sooner. Okay. But if you debride it very nicely, very minimal bacteria left, and you get like a good control with local antibiotics and IV antibiotics, symptom looks good, the exchange time will be longer, maybe 6 weeks. But if you put it in and 1, 2, 3 days, 1, 2, 3 weeks, there are another pus come out, you cannot just wait and see. You have to go inside debridement, remove the majority of bacteria out, because these local antibiotics can deal with only like a leftover bacteria, not like a big bulk or collection of the infection.
And also we have to look at that piece, the small piece, that too small piece. If it too much contamination or it's already look not good, it will be a source of infection. So I will remove it out early. Okay, not that big segment.
Not that big one. Okay.
Yeah. So repeat treatment is key, and also the antibiotic beads. I think if this look aggressive, I will change every time I get the treatment. But if not so, maybe 1 or 2 week change. Okay, let's say.
Okay. Unfortunately, the third operations, the last doctor bring everything out.
Let I ask about the wound. Do you know only the proximal wound or distal wound also?
He have a big wound here in the back of the forearm.
All along, you mean?
All along. The big one is the hole at the 7 week, but the previous scar is very long.
Okay.
Okay.
So what I think is that if the infection is only at the proximal, so the distal, maybe we can fix something.
Keep it, right.
Keep it and make it right sterile as possible and do it as a cross technique. But if it's open, so it's connecting all the way along, so it's maybe more difficult. Like in this state, I think they remove it out. Maybe it's not so good.
Yes. And after the third operation that the doctor bring everything out, the patient didn't know anything. I have no any document from him. This is the second cement antibiotics. I don't know how the doctor made it, but right now it's nearly popping out because the unstable fixation and the culture have a lot of gram-negative, including E. coli and Pseudomonas aeruginosa. So at this stage, what is your plan for this stage?
So we need to get aggressive debridement, so radical debridement, open all the way, proximal to distal, and get every necrotic tissue, and also the bone cement. Okay, and maybe we still keep the X-fix if it's not loosened. But if it loosened, maybe we need to exchange the X-fix. So it's the first step. But I think the get rid of infection is not that much important than bone lot is the very huge bone
Yes.
lot in this case. So, what is your opinion?
So pretty straightforward. We have to try to get rid of the infection first, right? The good thing or the bad thing, I don't know. There are not instruments inside there. We're supposed to be able to cure the infection. Once the infection is controlled, then we can think about bone reconstruction and soft tissue coverage later. So at this stage, it cannot be worse. Okay, so when you go inside, if you have a suspect soft tissue, you remove them all. Remove all the end of the bone. If you think it's suspect, it looks suspect, you can even trim it a little bit more just to make sure that it's radical and remove all the bad tissue. Add antibiotics, can be even multiple antibiotics locally, IV antibiotics. Do everything we can just to get rid of the infection, and then you have to discuss with the patient at this stage as well. Like, this is going to be a very long-term and unpredictable process. It's not going to be surgery 1-2 times and it's done, all right? But because this guy is so young, we're going to try our best to reconstruct it to have the best result for him. But because of it's going to be a very long process, he has severe nerve injury, you have to discuss with the patient what he expect. Can he go through all the process with us in this next year or two?
Uh-huh. Okay, the reason why the patient come here because the last doctor said that maybe he need to, yeah, yeah.
How about the nerve?
The nerve,
Nothing.
the nerve study, they are incomplete. Brachial plexus injury from C5 to T1, but they obviously seen that he able to grab the things, but the radial nerve is already gone. He cannot do wrist extensions. Okay, we proceed. So this is the timeline for him. So he meet me at around 26 July on the 7 in Thailand. So I take that cement out and put the antibiotic beads. With this case, I put 2 grams of vancomycin and debride at the operation room for 4 times. And after that, I put, after I'm sure that I remove the bad tissue out and the wound is clean. This is the wound. This is the antibiotic beads. After 4 times of the debridement, I remove the beads and plan to do the bone lengthening. Okay, I decided to put the cemented pin spacer to make the fibrous and prepare to release love. And for the external fixation, the pin is not loose. I just change the bar to the stronger one. And this is the picture after I put the cement pin. I possibly to close that wound because I think it's good enough. And after that, I manage him in the outpatient clinic. As you can see, the wound is quite very good. Okay, after 6 weeks of the pin cemented pin, we decided to start bone lengthening. Okay, this is the plan. Okay, this is the instruments that we prepare. So after the ESR-CFP is okay, the lab is, everything is okay, the wound is quite good, we start lengthening. So after 1.6 years, after 1.5 years, he lengthened it by himself. Then this is the plan. As you can see, the bone is quite good, come a long way, and there is no infection. This is the picture from Myanmar. I let him take the X-ray at the rural hospital and send me by the Viper at Myanmar. The wound is good, no infection. Right now, I don't give him any antibiotics. And this is the around 30 weeks after the distraction osteogenesis. This is the around 2 years after we have lengthening them. And this is the 98 weeks. We decide to do the elbow fusions. And this is the 15 months after fusions. He is doing very well with his nerve. Medial and ulnar nerve is still okay, but we plan to do the tendon transfer for his wrist extensor, but he decided to do that. He's postponed the operations. This is the final picture. He accepts the shortening of his arm. He can do his job very well. And this is 5 years from the first operations. There is no infections. Happens again. And then I still continue following up him.
So, congratulations.
Thank you.
Okay, thank you for the interesting case. Any comment or question from the floor? So if no, so I would like to close this section. Thank you for all of speaker and panelists. Thank you. The next section will be start on 11 o'clock.
Thank you ขอบคุณครับ